Hello and welcome to For Every Response, the podcast from Emergency Services Times. I'm Catherine Levin and I'm the editor of Emergency Services Times. In this podcast series, sponsored by MSA Safety, we have looked at many leaders. We've done 10 so far, and it's been a really interesting selection of people coming from different parts of the services with different backgrounds and perspectives on what it takes to increase public safety. We decided to add an extra episode, a bonus episode, if you like, to give you something else to think about over the summer holidays. I got to talk to two people from NHS in Wales, and we talked about anti-violence. You'll remember from back in the second episode of this series, Lana talked to Adam Hopper from the Association of Ambulance Chief Executives. They talked about reducing violence against paramedics. And as a result of us doing that episode, Gareth Lewis from the NHS in Wales spoke to Adam and said, I'd quite like to talk about what we're doing in Wales because I think what we're doing is really interesting. They have something called the Anti-Violence Collaborative. And having had a bit of a chat with him last week, I thought, well, let's get him onto the pod. Let's have an additional episode. And so what we have now is a half-hour conversation with him and his boss, Jonathan Webb, about how they in Wales are looking to reduce violence against not just paramedics, as we talked to with Adam, but with the NHS generally and their wider partners. So the collaborative part of that organisation is really important. And they talk about fire and police in particular, and Gareth himself is a former police officer himself. In the conversation, we'll talk a lot about standards, we'll talk about powers, but really it's about confidence to report, not looking necessarily about reducing the numbers of incident reporting, because actually the more reporting may mean that actually people are more confident. And I think that's one of the dilemmas that they'll have going forward in terms of judging their success. And we talk a little bit about that. So I don't want to give too much away, but just a little flavour of the conversation. So if you're interested in this subject, if you're interested in how your organisation can deal with violence, whether that's against firefighters, police officers, paramedics, then have a listen to this and see what they're doing. And do take time to go and have a look at the Anti-Violence Collaborative Wales to see the work they're doing, and enjoy this episode. I'm delighted today to be joined by Gareth Lewis and Jonathan Webb from the Anti-Violence Collaborative Wales. Welcome to you both.
Good afternoon.
Hi, Catherine.
The reason we're talking today is because Gareth had been speaking to Adam Hopper. Adam Hopper was one of the interviewees from one of our early podcast episodes, and he talked to Lana about violence against paramedics. The work that the Association of Ambulance Chief Executives is doing is covering a wide range of methods, but today we're going to find out about how it's working in Wales, starting with the NHS and embracing all of the emergency services. But before we get going with our conversation today, I'd like to introduce you to my guests and ask them to tell me a little bit about their background and why they're speaking to me today. So, Jonathan, can we start with you, please?
Absolutely, and it's good to meet everybody. So I'm Jonathan Webb. I'm a paramedic by background. I've worked in NHS Wales now for 9 years. I'm the head of safety and learning in the Welsh Risk Pool, and I chair the Anti-Violence Collaborative Wales.
And Gareth, would you like to introduce yourself?
Yes, thanks, Catherine. Gareth Lewis. So I work to Jonathan in the Welsh Risk Pool and Shared Services. My role is essentially managing this sort of fantastic project we've got. And my background prior to my current role was working in a local health board in a similar role, but just within the health board, if you like, dealing with violence. But my main sort of work history, if you like, is as a police officer, as a detective, where I specialised in sexual crime and offences against children.
Interesting that you've come from a police background. And Jonathan, yours is all health all the way, is it?
Yes, so I've worked in the health service since 1990. I did have a secondment actually to the police in health and safety and training role for a little while. So I've got some familiarity with our colleagues in the police service.
Excellent. All right, that's interesting to hear your background. So this series of the podcast has been very much based on conversations with leaders. And as health has devolved in Wales, along with fire, but not police, which remains with the Home Office, and we only have one ambulance service in Wales. So it's a very different situation we find in England. So to help me think through this pod today, I have looked at Healthier Wales, which is the long-term plan for health and social care. And it talks about the NHS being an exemplar employer and when it comes to the health and wellbeing of its workforce. So it sets the tone from the top. So when we're talking about violence against emergency service workers, that tone from the top is really important. So the work of the Anti-Violence Collaborative Wales helps the NHS meet part of this long-term plan. So I'm interested to ask Jonathan, first of all, about why do this? Why that tone from the top, that document, and how that flows through? They've clearly spent money employing you to do this piece of work. So what's your sort of take on where the government sees this work and its importance?
So I think right down through government and through the leadership of the NHS in all of the health bodies in Wales are committed to reducing and eliminating violence against our staff. And I think that's mirrored by the public opinion in this topic. What the Healthier Wales does is set a blueprint for how we achieve that. And I think the Anti-Violence Collaborative is exactly what it says on the tin. It's a collaboration. What I've found since working in the NHS in Wales is that the organisations want to collaborate. They want to get together. There are lots of All Wales guidelines and work streams that design All Wales solutions to try and avoid that postcode lottery that perhaps occurs inevitably of distributed services. So we've got absolute direction from the Cabinet Secretary that this topic is important. The NHS Leadership Forum, which is all the chief executives, actively support this. But it isn't just about the leadership, it's also about our staff associations and trade unions. The Welsh Partnership Forum very much supports the work of the collaborative and are active members of the collaboration.
And so, Gareth, were you brought in specifically to lead the collaborative work? Were you working on it before? How have you come to this?
Yes, I think when the Anti-Violence Collaborative first emerged, roles of what was titled Violence and Aggression Case Managers were created in each of the health boards. So that was in that health board, picking up the reports from staff and trying to help, essentially initially quite as a victim support role. So it wasn't really looking at prevention reduction. It was looking at how can we support that victim internally and if we need to connect to other organisations. So I think Jonathan recognised, as I think we all did, that agreement at that higher executive level and government level of Healthy Wales needed a link to the operational actions on the ground for staff. So the role I'm in now effectively bridges that gap.
And so in terms of the problem that you're trying to solve then, so the Anti-Violence Collaborative kind of almost says what's on the tin and in sort of bronze seal terms, but what does it mean? What is the actual problem you're trying to solve by coming together with all the emergency services in Wales to reduce violence? What does that mean in reality? What does that problem look like?
I think the problem we're trying to solve is about bringing people together, and that's not difficult to do. People are willingly participating in the collaborative, but at a case level, at a planning level, and at a strategic level, it's about bringing people together. So it's about looking at data, looking at themes and trends, trying to identify solutions, trying to look at how we can better use technology. And realistically also trying to deal with cases that have happened. So it is still, as you've had in your other podcast with Adam, it is still a prevalent problem in the NHS that we have to tackle. And obviously the numbers are too great. So what we're trying to do really is to get the right outcomes when something has happened, but also prevent future cases. And it isn't just about prosecution. The Crown Prosecution Service in Wales are an active participant in the collaboration, but it isn't just about court disposals of cases, it's about alternative solutions, which are very popular with our staff, because they feel that the chance of a repeat incident with that offender happening again is reduced. So that's where we're trying to sort of drive it from a pincer movement, really, a strategic data point, a strategic planning point, and an operational case leadership perspective.
Gareth, do you have anything to add on that point?
Yeah, just also I think healthier Wales, as you mentioned at the start, staff obviously want to attend work and be in a safe environment. Johnson just mentioned around how we are collecting all those areas and facets of violence and aggression. But I also think psychologically for staff, and I think across the UK several years ago, that zero tolerance title or approach is used a lot. But actually, what does that mean? Can you deliver zero tolerance? And I feel what we've done in the AVC is actually look pragmatically at what you can achieve for those staff, because it's a nice catchphrase, but what does that mean? I've had staff say to me, well, nothing really happened in the past, so what was that zero tolerance all about? So it's actually delivering something that people feel psychologically then that the environment is better.
So this idea of zero tolerance, is it actually achievable? Is it something that should even be part of the conversation? Is it possible to have zero tolerance?
Yeah, we say no. I feel in as much as if a case, for example, involving an assault of a nurse goes into the criminal justice system, the criminal justice system can't promise a particular outcome, can't deliver, it'll never happen again. You know, there's the court system, there's providing evidence. So zero tolerance sometimes, and I've had it from staff who felt that means it's going to get all sorted out, the person will be dealt with, they'll never have to be spoken to again about this. Then they get a court warning through. And then they say, well, I've got to go to court. So the criminal justice system is looking positively to help emergency workers, but it can't just sweep away the entire system. So I think sometimes it comes from a good place, but it can be a misleading soundbite.
Okay. And do you think that the existence of things like standards, so violence reduction standards in health boards, does that, again, it's kind of coming from the top again, that sort of setting the tone, but are they one of the tools that you can use to kind of create an atmosphere within organisations where it's not necessarily zero tolerance, but it's showing that you take it seriously, people will be listened to, there will be consequences, and they will see outcomes, the ones they want to see. So do standards help with that in terms of how it should look?
Yeah, definitely, in as much as it highlights the problem in a very clear, real way to an organisation whose primary goal is delivering healthcare. So we can't forget that the goal of a health board is health. Sounds obvious, but where then other things impinge on that delivery of health, it clearly sets out a tangible set of rules, if you like. Perhaps rules is too strong, or guidelines for that health board to look at. How are we measured against helping our staff? So Healthier Wales, how do we prevent the violence angle, that staff are not assaulted or they're going on sick leave? So have we got a lead that looks into this? Have we got staff that pick up the reports? What do we do with the reports? Can we find somebody to help with us? So without that clear guidance, it's easy for, in the great mass of a complicated day in the health board, for that to be not front and centre. So it clearly shows that health in Wales is taking violence against staff seriously.
I think the standards really do help, and talking to our colleagues in the NHS Leadership Forum, what it enables those colleagues to do at an executive level in a health body is to sort of focus on where the immediate priorities are. So it helps have a lens on it. It's not about Gareth and myself coming in and holding an organisation to account. That's not the purpose of the standard. The standards are to almost become a self-assessment tool and help drive that challenge, of course, that we can't escape from, in that funding is very tight. And therefore, you want to get maximum impact for the funding that the leadership team in a particular organisation have. So hopefully what that will do is give an opportunity for people to reflect and to analyse where they're at and to develop action plans for continuous improvement. So the standards don't mean that one day everything's a problem and the next day everything's fine. It's a continual improvement cycle. And of course, they're kind of evidence-based.
Okay, and so if you're doing that in the NHS, do you know whether the equivalent activities are happening in fire and police within Wales?
Yes, so our colleagues in the fire service in Wales joined the Anti-Violence Collaborative, and they've recently presented to us. Obviously, it's disappointing to me to hear of our firefighter colleagues experiencing violence and aggression operationally, as it is in the NHS. The numbers are different, which is good, but still the numbers are too high. Our colleagues in all the 4 police forces in Wales, although the criminal justice sector isn't devolved and it is a UK government matter, all 4 police forces in Wales are actively engaged, and they also have standards for equipment and training. But of course, they all vary. So there is nothing, the standards are very different between a police officer and a nurse or a doctor. But the principle of standards have been able to measure improvement on that.
And then just to complement that, to talk about legal powers. So I understand that there are legal powers for NHS staff to remove people who are causing a problem. Is that a Welsh power only, or does that exist in England or other parts of the...
No, in fact, the Enabling Act that produced this law was introduced in 2012. And it's been in place in England for that time. We're introducing it in Wales now for the first time, and I'm really grateful for our colleagues in Welsh Government support in doing that. And what we're trying to do is to ensure that the staff who are going to be empowered to take action are safe and trained and aware of what that happens. But again, it's not about them becoming like a police constable and removing people and start arresting people. It's not that kind of power. It's a way of identifying to people that their behaviour is unacceptable and that they're not able to be in the place where they've caused that problem.
And do you think staff, I want to Gareth, if you could cover this one, do you think staff will feel more confident that they will be supported because there is this legal power? Does it make any difference on the ground? Is it simply just a reassurance?
Yeah, I think it certainly can be a reassurance, but I feel it's quite unique in as much as a lot of the current offences to draw on for use in, to tackle a problem are obviously action by the police or police constable in the wording, etc. A lot of it relates to the Public Order Act, which is several years old. We're in 2025 now. We haven't had something which gives an NHS staff member the actual power themselves. So it is several facets to it. To me, there will be some trepidation initially, but we're putting together a comprehensive training package to alleviate obviously some of that, and it needs to be bedded in. But actually, if you think I've got the power legally behind me to act and to potentially remove a person who's disrupting a service or a clinic, so you can imagine 10, 20 people waiting, they may have been waiting some time on an NHS list, and they're going to be seen that day, and that service could be closed down. They may miss an appointment because of the behaviour of somebody. Actually, the ability to warn somebody, ultimately be removed, or have assistance for that person to be removed is important. It gives confidence. I feel it shows we're taking this topic very seriously. We're empowering our staff, but also to our colleagues in the police who are obviously very hard pushed with the volume of calls and the pressures they're under. They'll be able to see that the NHS actually are taking a step themselves. So it's not straight away over to the police. So I think the combination again is collaborative. So I feel that once the law is bedded in, then there's only good points from it. And
we're talking about NHS, but of course with the emergency services times where we're coming from is we're thinking very much about the ambulance service, so Welsh Ambulance covering the whole of the country. Does the power extend to the paramedics out and about in ambulances and in non-healthcare settings?
That's a very good point, actually. So it's the wording of the offence talks about hospitals and grounds, but also vehicles. So NHS vehicles. So again, that could well assist our colleagues in the Welsh Ambulance Service being able to take a step themselves, and potentially, somebody may be upset because they've had to wait several hours, or other things are going on, and just somebody being able to speak to them. Not everything is going to be somebody is physically dragged away, but it's that ability to have that power behind you, where at the moment it's just discretion of perhaps a confident person to speak to them with no legal backing.
This episode of the Emergency Services Times podcast is sponsored by MSA Safety, proudly supporting emergency services and first responders on the front line. At MSA Safety, protecting first responders isn't just what we do, it's who we are. We work closely with fire and rescue services across the UK to develop and deliver safety solutions designed to meet your ever-evolving needs. That includes MSA Bristol Firefighter PPE, trusted by services across the UK and beyond, shaped through years of collaboration with frontline teams. It also includes our growing investment in innovation and technology, from the connected M1 SCBA modular solution to our agile, fully managed service model that helps keep crews protected and ready to respond. But for us, safety goes beyond equipment. We believe in standing shoulder to shoulder with the people who dedicate their lives to protecting others, whether it's supporting firefighter charities, backing mental health initiatives, or showing up for community events. MSA is proud to be part of the emergency services family. To learn more about our work in the UK and how we're supporting first responders every step of the way, visit www.msasafety.com. With MSA Safety, when you go in, we go in with you.
I'm going to move us on now to talk about the collaboration part of the anti-violence collaborative, thinking about how you work with police, fire and ambulance, which you've both referenced throughout our conversation so far. There is something in Wales called the Joint Emergency Services Group, which is not, I don't think there's an equivalent in England that I can think of. I wonder, Gareth, if you could help us understand what that's about, where that's come from, and how having that in place is helping you with the work of your collaborative.
Yeah, sure. So the emergency services, the blue light services in Wales, and the military, including ambulance, it is a collaboration, similar lines, I guess, but the chief constables and equivalent meet regularly to collaborate across blue light, across military, but also look at data as provided. Johnson mentioned earlier, Gwent Police for Wales provide a specialist analyst service to that group, with very detailed, regular reports on the amount of assaults on staff, where, locations, types, etc., sort of really drilling down, which enables those organisations to look at what resources needs to be put in to alleviate those issues. So I've sat in some of those meetings, and they will highlight a particular geographical area. So under the skin, what's going on in that area, that can be looked at in a deeper level to say, well, we've got similar social economic areas down the road where it's not happening. So is there a particular problem? So it allows that spotlight on the issue, and where we are now involved, we bring the world of NHS data. So not just ambulance, not just the blue light, but all the other health and associated NHS Wales bodies where violence and aggression has been, unfortunately occurred, that we can bring that to that spotlight as well.
And the work of that group, did that start recently, or has that been going for some time?
Yeah, I believe, Jonathan, it's been going for some time now, isn't it?
Yeah, so it's been a collaboration of its own for a number of years, driven by a couple of leaders several years ago, but it's been in place for about 10 years in its current form. And the data that is produced really helps us support the agenda. It's important to recognise that the data isn't just for the blue light responders, and the whole of the NHS is included, but the Joint Emergency Services Group are that Category 1 first responder blue light services that we all recognise that support us in our daily lives.
Thinking about that group and thinking about some work that's been done by Audit Wales, in 2022, they did a review of joint working between emergency services. And in there is actually an example of your work. So I wonder if you could tell us a little bit about that. It was around a joint information campaign about violence against emergency services workers, but that was 3 years ago. So perhaps if we could, Gareth, if you could just give us a little bit of background about the report, that example, and where you are today, 3 years on.
Yes, absolutely. So we've worked in the last 18 months, 2 years since the Anti-Violence Collaborative as a sort of refresh post-COVID pandemic. We've worked to promote what we do and who we are around Wales, and a very good example will be with the Welsh Ambulance Service. They've worked on a very successful and public-facing campaign of support us, with us, not against us. Vehicles will have information on the back of them. You've only got to be behind one of the sort of blue light vehicles to see that information regularly in the media, in and across Wales and social media. So and I've had calls and communications from people from all over Wales and outside of Wales about that. Can you tell us a bit more about this collaboration? What are you doing? How do you reduce it? So I think that's testament to the fact that we are more out there, if you like, for want of a better term.
I think what's also developed since that Audit Wales report, Catherine, is the work that we've done around Form G. Now, just like many NHS forms, the acronym G is very historic. We're good at abbreviating things, but Form G is about mental health in violent settings. And I think that what the Audit Wales report highlighted is that there is a challenge often in dealing with service users that may have a mental health presentation, and their behaviour is still unacceptable. What Form G provides is a mechanism for organisations to quickly identify that somebody had capacity at the time of the alleged offence, and therefore drive towards a solution, which may not necessarily be a court solution, but it means that the person who is impacted doesn't feel that the police, in inverted commas, because it's the whole criminal justice sector, the police aren't doing anything because this service user had a mental health diagnosis. It also, having talked to police officers, it provides a little bit of a framework for them to say, actually, it's okay. I can take somebody into custody. They may be fit for interview, and it stops a lot of delays in getting that evidence to a point where it can become suitable. So I think that was one of the findings from Audit Wales, that mental health was a prevalent issue. Obviously, it still is a prevalent issue in the data, but what we've introduced, and we recently spoke to the Association of Ambulance Chief Executive Specialist Group on this, is the impact of this Form G in Wales has meant that far more cases have progressed than if it hadn't existed. And it's really just an opportunity for a clinician to map out for a police officer and for the CPS why they feel the person was aware of what they were doing, and then it wasn't something that was, shall we say, clinically explainable.
And do you see this Form G working in NHS England, or is that already happening?
Well, we, as I say, we did a presentation to the specialist group in the ambulance service, and obviously there's a lot of pressure on services at the moment, which is well documented. But there's certainly an appetite to take it forward, and we would work with any regional teams, any police forces that want to introduce it. It's easily available on our website, but obviously we can provide some background and training to officers and staff.
Great. So let's talk now about data, because you have both mentioned data quite a few times in this conversation, and we talked about the problem at the beginning, and often when you understand the problem, you need good data to help you understand the problem. And also you need the data at the other end to help you understand whether you've succeeded and got to where you want to get to. So I'm interested in how you've set a baseline for this. So if violence is 100 now and you want to get it down to 10, what does that baseline look like in terms of practical reality, and how are you going to use these tools to get to the end to measure success? So can we just sort of look at the sort of bookends of data? So where do we start from? How do you create your baseline?
I think Catherine's understanding said that besides the problem, for example, I worked in a medium-sized health board, and annually there was around 4,000 violence and aggression reports of violence and aggression. Sounds dramatic, but that would include right from where you'd have perhaps a very elderly person with a medical condition causing a scratch on a nurse's arm. There was no criminal intent, etc., right away through to perhaps some serious offences. So I think understanding the landscape, so how much of that is actually something is clinical, how much is criminal, and then from what you determine is criminal. For example, we will look at on our report, physical, verbal assault. Is there anything that's racially aggravated or along those lines? So we have been working clearly and with one particular health board very clearly and obviously to identify key markers of offending and accuracy, and I'm sure Jonathan would agree with me, accuracy of recording. So in fairness to reporters, if the reporting tool isn't very clear, then we can have a variety of responses. So something like an aggressive behaviour. What does aggressive behaviour mean to yourself, to me, to Jonathan? We may have 3 different definitions if you asked us. So it's ensuring that the tool is clear, and then from the information we receive, we can use all of the things we've talked about today in our group to look at how you can prevent, or if it is not a prevention, it needs a prosecution, how do we make that flow? So I think initially at the start of the journey is a clear recording system that people are confident to use.
I think that's absolutely right. What we don't have yet, Catherine, is a clear baseline of exact numbers. And I think that's partly due to the fact that, very sadly, some staff are not reporting incidents that they're experiencing. And there's a multitude of reasons for that. But some because it's become a normalized situation, and that's so disappointing to hear. But also because staff are not confident that something would happen. Why would I take time out of my hectic clinical day to report an incident if nothing's going to happen? So I think we've got to do 2 things at baseline stage. I think we've got to cleanse the data we've got to make sure it's accurate. And as Gareth said, we worked as a pilot with one of our largest health boards to do that. And it's been very successful and not as time consuming as it would first sound. We've also got to provide enough tools to colleagues in the NHS so that they feel that it's worth reporting. So I'm not sure that the baseline is clear. I don't think we have a number of each type that we can say this is our starting point and we need to see it go down. I think what I probably expect to happen is that numbers increase initially as people become more confident of incident reporting practices and the publicity that we shine a light on the outcomes that we achieve. So I'd love to be able to say there is a number, but I don't think there is a baseline number yet.
That's interesting. That's exactly what I was thinking when you were talking, which was that actually your numbers probably will go up, because if people become confident because the tools that you put in place and the processes give them the confidence to report, then they're going to go up. So I suppose really it's not a numbers game on this one. It's more about outcomes which are softer and about confidence, and maybe it's more about surveying how people feel as the employers, how you are treating them and how they're providing an environment in which they can feel safe and confident to work. So it'd be interesting to talk to you perhaps in a couple of years and see whether you've looked at those confidence levels and whether you could take those confidence levels now as like a kind of baseline. So just conscious of time, I'd like to talk a little bit about impacts now around what difference does it make. So we talked about confidence of staff there, but what about in terms of call outs, impact on your partners, the CPS, reduced numbers of victims? Are there other impacts or things that you're particularly looking to achieve through your work?
think for me, and I think it's evidenced by the sort of calls I receive on a weekly basis, which are increased as time has moved on, is the trying to make the system more efficient for the best result. So what I mean by that is trying to take away the frustrations of all the different public sector staff that are involved in a complaint. So if you took a classic assault in an A&E department where the NHS colleague wanted to proceed with a criminal outcome, it involves obviously the police, it involves NHS staff to give statements, it involves perhaps security to run through CCTV, the officer's time to put the case together, the CPS's time to review it, etc. So what we find in terms of outcomes or positive results, if you like, we have lots of evidence from colleagues across Wales where thank you very much for getting involved with XYZ. This is now proceeding, or thank you, we're not going to a criminal route, but we're really happy with this outcome, or we've risk assessed in a different way, because that's another key element, I think. NHS Wales and all NHS organisations are used to clinically assessing their areas and their work, but we will say, what about from a violence and aggression viewpoint? For example, there could be several reports in a particular area where by risk assessing, how many staff do we have? Where do we have people waiting? Real practical, physical things that our experience is starting to assist in that. So we get a lot of anecdotal evidence that thank you, that's really helped. So it's ease in the without perhaps on our last point, a very obvious sort of bean counting, if you like. There was 10 and now there's 7, but actually it's softer where you get those reports of actually, this situation has eased now.
I think that's absolutely right, and I think the violence prevention and reduction standards will hopefully help towards staff feeling safer in their working environment by not just the number of incidents going down, but the physical infrastructure that we have improving, and being able to drive the investment, the limited investment that we've got in the right way. So I think the investment, the impact is multifactorial, but it needs to be both at a very individual case level. Every member of staff, the NHS in Wales is important, and they all need to feel safer at work. But also we need to be able to measure and assess that, and those standards will hopefully help us to do that.
So as we come to the end of our conversation, just like to think about all of the range of things that you've talked about today, and thinking about how you reduce violence, how it's about staff perceptions, about how you create an environment where actually we're not going to see physical. I mean, interesting you mentioned there about infrastructure in terms of hospital waiting rooms perhaps not being bashed because we're not seeing the kind of violence that maybe some hospitals have experienced. So I wonder, to finish this conversation today, whether you could give some advice for our podcast listeners. So out of everything that we've talked about today, what is one key thing that each of you would like to highlight as something that they should go away and think about, and perhaps consider talking to colleagues about that in perhaps when they're back in the office? But start with you, Gareth, please.
Sure. I've had quite a few calls, queries, discussions with colleagues in other parts of the UK, and obviously particularly England being the biggest country and more complex in the amount of organisations. Oh, it's great for Wales. That looks so good. We wish we would have something like that. And I would say to colleagues out there, think regionally in your area, and actually thinking on the size of Wales, the amount of police forces, the setup of the CPS, etc. I think it could be achievable if you think regionally. Could we have a regional version? So, for example, East Anglia, could you look at the police forces that cover that area? What CPS office covers it? What health organisations are in that area? And it would probably find it replicates the size of perhaps Wales. So just as an example. So I think my tip or advice would be think regionally and try and put that group together.
Great, thank you. Jonathan, what's your piece of advice?
I think it's about information at an individual level. I entirely agree with everything Gareth said, but for me, my advice is to the individual member of staff. Everybody who is the NHS, and therefore it wouldn't be the organisation it is without its people. So reporting of what's happening, sharing of intelligence, documenting what's happened, and recognising that the vast majority of the public agree with us all that a behaviour that we do see very occasionally, whether it's to our paramedics, our frontline staff, our office staff, our clinic planning staff, our domestic staff, is unacceptable. So report what happens and don't accept silence if you don't hear anything when you report. If you're in Wales, phone me.
Lovely. Thank you very much to you both for that. What a great conversation. Just leaves me to say thank you very much for joining me.
Thank you.
Thank you, Catherine.
Thanks for listening, and thanks to Tom St. John for expertly producing this episode. If you like this episode, then be sure to check out other conversations with leaders in this season of For Every Response, sponsored by MSA Safety. Share the link and subscribe to receive updates on new episodes from us here at Emergency Services Times.